This is the PANRE review. We'll be doing cardiology part 2. My goal is to be short, simple, and relevant. And with that, let's get moving. So we're going to start by talking about aortic dissection. What is aortic dissection? By definition, it is a tear in the aorta. An aortic dissection is very serious in the sense that it has a 30% mortality. It's acute, but can be small enough to generate symptoms for 2 or more weeks. So aortic dissection, what would cause a tear in the aorta? What are the causes or some of the risks associated with this? Aortic dissection can occur from trauma. The ones that we talk about in terms of medical pathology, your main risk factors are going to be some sort of connective tissue disorder. That would include Marfan syndrome and Ehlers-Danlos. Another one of the risk factors for an aortic dissection would be age. The aortic dissection, the aorta can become weakened with chronic hypertension as well, and that would be another one of the influences behind age, that if you have hypertension for many years and over the years as you get older, you may be at higher risk for an aortic dissection. What are the signs and symptoms associated with aortic dissection? So think for a second, what symptoms would occur in an aortic dissection? The buzzword is sudden tearing chest pain. It may cause just general chest pain, radiating pain. Things that you may see on a test question would be radiating pain to the arm or the jaw. Syncope, presyncope, dyspnea, coughing up blood, anxiety, premonition of death. So very severe dramatic symptoms. Generally the chest pain alone is enough to get people's attention. There are different versions of aortic dissection. It can be an abdominal or a thoracic aortic aneurysm. So those are 2 types of aneurysms that occur, and we'll go into greater depth with both of those, a AAA and a TAA. How is it diagnosed? Well, a CT scan would be definitive. An X-ray may show what? So this is another buzzword moment. An X-ray may show a widened mediastinum, but the CT is going to be a definitive diagnosis for a thoracic or an abdominal aortic aneurysm. How do you treat this? Well, in terms of an aneurysm, you can watch it. You may have to go through and treat it surgically. If there was a complete dissection, the only way that that's getting better is going to be with surgery. They will do endovascular repair or a Dacron graft. So what is the treatment of an aortic dissection? It is surgery, Dacron graft. So looking more specifically and closer at an AAA, so abdominal aortic aneurysm, 13th leading cause of death. The risk, greater than 65-year-old, Marfan syndrome, or connective tissue disorders. What other things may lead to some of the weakening and aneurysm, expansion, widening of these vessels? Smoking, COPD, and hypertension are other risk factors that can weaken these vessels and put people at risk for an aortic aneurysm. So the signs and symptoms of this are non-specific. It will be if there's a dissection, then you'll have that sudden tearing pain, and the way that you can catch that again is an X-ray or a CT scan. This is not going to be, it's going to be different from a myocardial infarction, because the myocardial infarction, we say chest pain, you get an EKG, you may run cardiac enzymes, and you may not see many of those changes on the EKG, and they could still have a serious condition. So X-ray and CT scan are going to be the only way to pick that up. In terms of an aneurysm, you may also be able to detect that through an ultrasound. So an aneurysm, abdominal aortic aneurysm, you can see how wide it is. And so the thing is with an aneurysm, because the aneurysm is the risk for the dissection, what was noted on eMedicine is that the treatment, it depends on how wide the vessel is. So if it is 4 to 4.9 centimeters, then you can just do yearly screening. If it is greater than 5.5 centimeters, that's when they suggest surgery. So one of the other signs and symptoms, this would be a buzzword. So we went over some of the non-specific, but it could be back or flank pain, sometimes insidious groin pain. But if you were to find what on physical exam, or what would you find on a physical exam that would be indicative of an abdominal aortic aneurysm? The key word there is a pulsatile mass on palpation. So going to a thoracic aortic aneurysm, a thoracic aortic aneurysm is a dilation. So an aneurysm in general, by definition, would be a dilation of an artery that is 50% greater than normal. Most aneurysms, aortic aneurysms, are going to be abdominal, so the thoracic is less common. The diagnosis of this one is different because an abdominal aortic aneurysm, like on physical exam, you could probably put your fingers there and you could feel the pulsatile mass. However, with a thoracic, that's a little bit higher. You have your whole rib cage that's protecting and shielding that area, so you're not going to be able to detect that through an ultrasound. The CT scan is what's going to be needed to diagnose the thoracic aortic aneurysm. So that's where that fits into that whole picture for diagnostic reasons. Again, the risk factors are the same. So what are the risk factors for aortic aneurysm and aortic dissection? That would be a connective tissue disorder. Two examples of that would be Marfan syndrome and Ehlers-Danlos syndrome. The other would be age, so someone that's greater than the age of 65. You may want to consider that. But also the people that have high risk factors for an aneurysm, chronic hypertension, smoking. So the treatment for both the abdominal and the thoracic is going to be some sort of cardiovascular surgery. The numbers that were given from eMedicine are that you would repair it at 5.5 centimeters to 6.5 centimeters is when you would actually go through and do the surgery. In terms of the signs and symptoms, for the most part, if it's an aneurysm, again, they may not be actually noticing that. So the most common way that a thoracic aneurysm is diagnosed is its diagnosis is going to come pretty much incidentally. So the workup, again, if a patient presented with chest pain and they had a lot of risk factors and you didn't think that it was safe to just send them home, you may consider, okay, we might have to rule out a thoracic aneurysm, and so a CT scan may be included in the whole cardiac workup of chest pain, depending on what, again, if you're in an emergency room, they probably just add that to the list of things as part of the general workup. So those are aneurysms and dissections of the aorta. Moving onward, if you had a patient that just all of a sudden, if you heard a story of a person, maybe in their 20s, that just all of a sudden fell down and died, what would you consider that could have been influential in that? One of the things that is a buzzword for, a buzz case, would be sudden cardiac death in an adult, especially in a younger adult that doesn't have those risk factors for a myocardial infarction, would be hypertrophic cardiomyopathy. What is hypertrophic cardiomyopathy? Hypertrophic cardiomyopathy is increased left ventricular thickness. This actually affects the functionality of the heart to pump and fill in a negative way. The hypertrophic cardiomyopathy is the story that you get of a lot of athletic people who all of a sudden just fall down dead in the middle of a game. This is complicated because it can just show up and people die. They're not presenting, and so the signs and symptoms could be the dyspnea on exertion, syncope, pre-syncope, angia, pain, chest pain on exertion. In a rare case, maybe they are showing some signs of congestive heart failure or systolic heart failure, dizziness, postural nocturnal dyspnea, and palpitations. So a lot of this is the way that you got to look at hypertrophic cardiomyopathy is if you have an adult who is presenting with complaint of palpitations in their heart or episodes of dizziness, just getting tired with exertion or chest pain on exertion or dizzy with exertion, anything like that, you're probably going to want to look in getting an echocardiogram. I think I actually have one great thing that I did in family medicine, and it was a patient presenting with fatigue and fatigue with exertion, and we sent them for an echo, and they ended up finding a significant cardiac anomaly. I don't think it was this specifically, hypertrophic cardiomyopathy, but they did find a serious heart problem, which they were able to repair with surgery. And the cardiologist said, had they not picked that up, it may have ended his life. So the main thing that you need to remember in a clinical setting is, what are you going to do with somebody who has dyspnea on exertion? As soon as you hear that, you should be thinking this person needs a cardiac workup, EKG, maybe you run through the whole thing, but you're also going to want to look at getting an echocardiogram to evaluate the anatomy of the heart and see if there's anything wrong there. So one of the things that you'll see on the echocardiogram would be left ventricular hypertrophy wall thickness. Generally, it's greater than 15 millimeters. The treatment is obviously you're going to refer to a cardiologist where they will be doing surgery. They may actually, and if they don't do the surgery, then they may just recommend that the individual avoid strenuous exercise. And so that is hypertrophic cardiomyopathy. The next is this would be a bacterial infection of the heart. So a bacterial infection of the heart, the one that we're referring to try and get your mind to guess what it is bacterial endocarditis. Bacterial endocarditis is what you think of with fever and heart murmur. Fever and heart murmur, it may be fever and chest pain as well, is something that you could think of. So bacterial endocarditis is an infection of the endocardial wall, which is the inner wall of the heart. The inner wall of the heart most often is going to be a reference to the valves of the heart. So you get this bacterial growth on the valves, and the valves are included in the endocardium. What bacteria are most common in endocarditis? I know this is a little bit specific. What are the most common bacteria? The most common type of bacterial infection or bacteria involved in bacterial endocarditis is Staphylococcus. Staphylococcus is the most common. It could be a strep infection, so strep viridin, strep bovis, and enterococci are also common, but the most common is Staphylococcus, and they list that about 25% of cases. How do you get the diagnosis of this? So chest pain or a heart murmur plus a fever, that would be a new onset heart murmur that would really key you onto this. The patient may be presenting with acute symptoms that are representative of some sort of systolic failure. So if the individual started to have edema, dyspnea on exertion, chest pain, swelling, some of that RALS, the postural nocturnal dyspnea, or the just cough at night, those are things that could be indicative of a bacterial endocarditis. The other things, though, because some of that is non-specific. Now you're saying, well, chest pain should be pretty specific. Like if you have a general flu or an upper respiratory infection, you usually aren't getting isolated chest pain. So if you have an illness plus chest pain, you're probably obligated at that point to rule out endocarditis or some sort of infection, whether it's viral or a bacterial infection of the heart. The other things that are some good buzzwords, so people who write tests love to write tests about these because these are some unique findings. So if an individual had some hemorrhages in their nails, that could be an indication of bacterial endocarditis. Now, especially not just that alone, but you also put that with the sequelae of the other symptoms. So splinter hemorrhages would be hemorrhages that are kind of being sent off, and as the heart is pumping the blood, those splinter hemorrhages are going off into the nail beds, and there's things that you can see, these little brown spots in the fingernails. You may also have Roth spots, which are also hemorrhages, but are found in the retina. If you had a very advanced way to examine the retina, that would be something that you could see. So again, it would be retinal hemorrhages. The other thing that you see are Osler's nodes. Osler's nodes are nodules on the digits. And then you have Janeway lesions. Janeway lesions are non-tender macules on the palms and the soles. What other conditions are we aware of that cause some sort of rash on the palms or on the soles? Is syphilis, as well as, I believe, Rocky Mountain spotted fever can cause those. But there's also, if you're having macules on the palms and the soles, those could be Janeway lesions and an indication that a person has had bacterial endocarditis. What are some of the risk factors? Well, one of the main risk factors for bacterial endocarditis is going to be IV drug use. People who are using drugs, they'll put in a needle, and that needle has the infection, and so that the bacteria gets into the blood via a non-sterile needle, and then that bacteria is able to get at the heart where things are pooling, and that's where you're going to see it get on the valves most often. Signs and symptoms: fever plus heart murmur, dyspnea, chest pain, heart failure symptoms. The diagnostics. So the diagnosis of bacterial endocarditis is 2 major criteria: 1 major, 3 minor, or 0 major and 5 minor. Blood culture, echo with a mass. So really, if you did an echocardiogram on this person, because why? They presented with a fever and they had chest pain, and you said, well, fever and chest pain, if it's really that localized in the chest, we need to rule out endocarditis. You do an echocardiogram and you can see a mass on that. You probably also want to get a blood culture, because in case the echo doesn't pick it up, so the blood culture will be able to identify, 1, it will help you for your treatment, and 2, it'll help with the diagnosis of bacterial endocarditis. The fever is usually greater than 104, and that would be a minor criteria. Other minor criteria could be a vascular phenomena. That would be something like splinter hemorrhages or Roth spots. Risk factors: IV drug use, that would be enough to count as a minor criteria. Immunologic phenomena, and those immunologic phenomena, I believe, are like the Osler's nodes, because those tend to be more painful. So, what do we call this criteria that has the 2 major, or the 1 major, 3 minor, 0 major, 5 minor? This is referred to as Duke criteria. So Duke criteria is useful in the diagnosis of bacterial endocarditis, but the echo is going to be one of the main things, but that in alone and of itself may not be enough. So if you are suspicious of this, remember, get an echo and do a blood culture. And make sure that you're listening when you're doing your physical exam and you hear a murmur, because a murmur, I believe, is also something that we can include it as like a major criteria. So what is the treatment? Because it is a bacterial infection, you would treat this with IV antibiotics. What are the primary antibiotics? Penicillin G and gentamicin are the 2 antibiotics that are used. I don't know if that's a combo or if it's one or the other. That's just what I had written down from eMedicine. So moving onward, hypercholesterolemia. What is hypercholesterolemia? This is a pretty common one. Hypercholesterolemia means that you have high cholesterol. There is good cholesterol and bad cholesterol. What is the name of the good cholesterol? That is HDL. The LDL, the low density lipoproteins, are going to be the bad cholesterol, and the ones that are more associated with coronary artery disease and cardiovascular risk. So if you recall from the first part of cardiology, we went over a way of assessing risk for coronary artery disease, and this is known as what? How do we assess the risk? This is the Framingham Risk Score. Generally, hypercholesterolemia is something that is pretty easy to catch because it's caught on routine screening. When an individual presents for a physical exam, just a general health checkup, at a certain age, you may start to just screen. And what it says, at what age would you screen men? It says screen men at 35 years old. If they have risk factors, though, maybe a family history, you can start screening as early as 20 years old. So the diagnostics of hypercholesterolemia is made pretty simply through lab work, routine screening. The signs and symptoms, though, so you want to also think of this in terms of what are the consequences of hypercholesterolemia. If it's causing atherosclerosis, then and you're getting that in the vessels of the heart, you would be having angina and pain. If you were getting atherosclerosis in something like the iliac artery, which we'll cover later, you will be presenting with symptoms of claudication. So that would be peripheral arterial disease. So you have cardio, CAD, and coronary artery disease, but also peripheral artery disease. And so those syndromes would be something that would make you think that this person has high cholesterol. The other would be something called a xanthoma. What is a xanthoma? Xanthoma is like a cholesterol deposit in the skin. Treatment. How do we treat hypercholesterol, high cholesterol? The number one treatment is a statin. So think of a name of a statin. There is the two most common would be probably simvastatin and pravastatin. Lipitor is, I believe, the most common one that is prescribed. What are some other treatments that we use to lower LDL cholesterol? That would be fibrates, niacin, and bile acid sequester medication. So fenofibrate is the name of one of those. Niacin is just a vitamin that you can prescribe. Also, omega-3 fatty acids have been shown to decrease LDL. Dietary changes is probably the first thing that you could think of in terms of treatment, which would be to lower the amount of cholesterol that you're eating in your diet. That would come from animal products, including cheese and milk and meats, and a lot of the just things that are not freshly made. Anything that's going to be microwave quick usually they've added a lot of stuff to it that has high cholesterol. So it used to be the goal was to keep the LDL below 100. Now that it depends on the certain risk factors, because if someone had a severe risk factor, you probably want the LDL as low as 50, depending on the individual. If they have a lot of risk factors, then you want the LDL to be less than 70. If they have just general moderate risk factors, then the LDL is 100. So I know there's a lot of controversy currently when it comes to LDL and the actual risk that is associated with it, but this is the standard still. So some people would say, depending on the individual, because it can have such a strong genetic component, if you're unable to lower it, sometimes it may be reasonable just to set the goal to reduce the cholesterol by 50%, especially if the patient's having some severe side effects because of the medication. Now, what is the primary side effect that's associated with statins? The primary side effect associated with statins is pain, just body aches and pain. So similar to hypercholesterolemia, we have hypertriglyceridemia. Hypertriglyceridemia is separate from cholesterol, so triglycerides is just fat, and that's something that is also going to be detected in routine screening when you're running your lipid profile, the lipid panel. It'll give you your LDL, it'll give you your HDL, but it will also give you your triglycerides. So triglycerides, the criteria for you, that if you can just try and pull this out of your head, at what point would you need to treat hypertriglyceridemia? If the triglycerides are higher than 500, then you need to treat. If the triglycerides were higher than 1,000, you need to treat very aggressively. What is the primary treatment? The primary treatment is going to be dietary changes. Are there symptoms with hypertriglyceridemia? Well, it's generally asymptomatic unless it starts to go above 1,000 to 2,000 milligrams per deciliter. At that point, you may start to see similar things like xanthomas, peripheral artery disease, or lipomas, or a fatty liver. So lipomas are something that you'll find in general physical exam. People will say there's like a mass and you'll feel it, and it's like this big squishy bump inside of them. It's kind of, this may sound a little strange, but it's similar to like breast tissue, but it can be found on any spot of the body. It's not breast tissue, and there are differences, but I'm just trying to give a little bit of a distinction. So a lipoma, what is the treatment of a lipoma? Just observation. If the individual is really bothered by it or it's causing pain, you can do an excision of a lipoma. That's something that will be done often in general medicine, but could be, depending on the location, you may refer that outward to a general surgeon, depending on who wants to do it and who's comfortable doing it. Also, signs of hypertriglyceridemia. There's a particular organ that is associated with hypertriglyceridemia. So if you have too much triglycerides, it can affect your liver. Fatty liver. So think of fatty liver. That may be another reason why you'd want to treat to preserve the functionality of your liver. So the treatment, number one, is diet. It would be a low-fat diet, but there are some other things that we use in terms of treatment. Now, statins are good at lowering cholesterol, but what is good at lowering triglycerides? So fibric acid medications, fenofibrate or gemfibrozil. So those are your primary ones. Those are the second line in high cholesterol, but are the first line in hypertriglyceridemia. Niacin has been shown to decrease it. Omega-3s can decrease it a little bit. Statins may decrease it as well a little bit, but the primary ones, it looks like the treatment was fibric acid medications. So the next thing that I have is DVT. DVT stands for deep vein thrombosis. What is the sign of a DVT? Signs and symptoms associated with DVT. I want you to try and pull these ones off the top of your head because they're very important to know. Calf pain, leg pain, chest pain, tenderness to palpation. You may see signs of warmth and you may have edema. What is the most specific symptom of a DVT? It is not pain in the calf. It is actually edema, swelling in the calf. It would usually be unilateral on the actual leg that has the DVT, and that edema would generally arise quite suddenly because obviously congestive heart failure is going to be in both feet. So this patient, they have no other symptoms, and it's like, hey, yesterday I was fine. The next day I start to get a bunch of edema in my leg. Then you're going to need to run what? What is the specific test whenever you're thinking of DVT? It is a ultrasound of the leg. So before we go into the diagnostics, I want to go back to the signs and symptoms. There is another sign that's often described on tests. One of the signs of a DVT would be a tenderness to palpation, but there is something where you will, I think it's dorsiflexion of the calf or dorsiflexion of the ankle, which will stretch the calf, and they call that a Homan sign. Just as a matter of epidemiology, DVT can lead to a pulmonary embolism, and pulmonary embolism causes about 300,000 deaths a year. So this is a very significant one, which is why you need to know this one quite thoroughly. There is a thing to help assess pulmonary embolism, since pulmonary embolism is covered more so in the pulmonary module. So we won't go into great detail on that, but what is the name of the criteria to help assess a pulmonary embolism? That criteria is called Wells criteria. Pulmonary embolisms are the great bane of all medicine because they're somewhat nonspecific and they can be very hard to catch. One of the things that we look at the most when it comes to whether it's a DVT or a pulmonary embolism is you want to know what the risk factors are. So the main risk factors that are associated with a DVT are going to be immobility, so someone who has not been moving very much, traveling like by plane, because a lot of times that is that immobility. They're just sitting there for hours and hours and hours, and the blood can pool in the legs, as well as a recent surgery, as well as some hypercoagulable state. So this person has a history of a hypercoagulable condition that we would cover in hematology. That those are going to be your three main risk factors, and anyone who has one of those three and an onset of chest pain, get the ultrasound. What I've seen a lot of times is it's very often after surgery. If anyone has any did I say chest pain earlier? I meant to say calf pain. If anyone has any calf pain post-surgery at all, even if it's a week or two past that, you're going to want to get an ultrasound just to rule it out. In fact, the main thing that you're trying to distinguish from would be some sort of athletic injury versus a DVT. So if someone has no risk factors and they've been exercising, specifically things that put a lot of strain on the calf, then maybe that would be someone based off of that history. You may not be looking in the direction of a DVT, but if a person is particularly sedentary, has no change in their activity, and has calf pain, you're probably going to want to just be safe and get an ultrasound, and the ultrasound will be diagnostic for it. But once you diagnose this, you have a deep vein thrombosis, which is a clot in the vein. What is your goal? Your goal is to treat with a anticoagulable medication. The ones that are used are heparin, warfarin, and factor Xa inhibitors. So the factor Xa inhibitor ones are awesome because they're very simple and you don't have to do a lot of blood testing along the way, but insurances often don't cover them, or at least they didn't about 6 or 7 years ago. The names of those medications are what? The cool ones that we use to treat DVT with would be Xarelto or Eliquis. The ones that are traditionally used to treat are going to be heparin and warfarin. Warfarin is probably one of the most common. Your goal with the treatment of warfarin is what? Because with warfarin, you are doing blood work routinely, and that blood work is designed to test what is known as an INR. And the goal for treatment in a DVT is going to be to get that INR in a 2 to 3 range. And in medicine, you run into that a lot, and you're always adjusting the amount of dosing, the scheduling on dosing for warfarin. Heparin can also be used. That's 80 units per kilogram. Kilogram times 1 IV is something that I had written down from eMedicine. But most of the time, the thing with with a thrombosis is the main thing that you're going to be using is you want to, the clot doesn't just go away. The clot actually stays there for quite a while. It takes a long time to break down the clot. So the main reason that you're actually treating is to prevent future clots from occurring, especially in the lungs. That would be a pulmonary embolism. But also, I mean, thromboses can occur in all sorts of places. They don't, the calf is one of the most common. The other common place is going to be in your lungs. They can also occlude in a coronary artery, but they can also occlude in the brain and cause some sort of a stroke. So it's worth knowing some of that pathophysiology associated with this. Venous insufficiency. So while we're on the idea of veins, venous insufficiency would be defined as what? So if you think about it, insufficiency, it is an insufficiency in the veins, blood flowing / reflux backward in a congested leg. What happens is there you have incompetent valves in the legs, and so there's a tremendous much more amount of blood that just pools in the veins, and you can visually see this by noticing varicose veins or varicosities. So venous insufficiency, if you remember Virchow's triad is venous stasis, endothelial trauma, or endothelial injury, as well as hypercoagulability. Hard to say. So, Virchow's triad, you probably, as we're just talking about DVT, varicosities, as well as venous insufficiency, it's just good to review Virchow's triad because that shows up all of the time. So, deep vein insufficiency usually results from what? So, how does this cause? So, you have this incompetence of the valves. Why do the valves become incompetent? Some of it could be genetics, but one of the main causes is actually going to be a DVT. If you get a thrombosis or a clot somewhere, then the vessels there start to burst and the valves can break as a result of all the pooling and the blockage that occurred. Signs and symptoms would be cramping, burning, swelling, aching, feeling heavy and fatigued. Telangiectasis, those are like little spiderweb vessels that will show around. So the individual, you may be actually to feel some sort of a cord-like mass if there is some inflammation in one of the veins, and it could be a little bit tender, and it would be cramping, burning, and swelling and aching. You may want to do what? Because this patient is complaining about some sort of pain, this is typically in the legs, you probably want to get an ultrasound. Why? Because you want to rule out a DVT. Why? Because a DVT is a serious condition that can lead to a pulmonary embolism or a stroke or something very serious that could kill or debilitate an individual. So you want to make sure that that has been ruled out. Now, if it's not a DVT and then you find out, okay, this is just venous insufficiency, what can you do about this? Compression socks may be helpful. There is a lot of vascular surgery that is done to kind of help correct the venous insufficiency, and that's usually done by a vascular surgeon. So those are really the main things that we do to treat. And so this would be something that people find because they have calf pain, and when they have that pain, you do the ultrasound. And if it's not a DVT, if it's not a clot, then they may just have venous insufficiency. And you can also get some phlebitis or thrombophlebitis, so it's worth looking at that. So phlebitis, as the name would specifically suggest, is inflammation of the veins. It could be inflammation of the veins or thrombophlebitis, which is inflammation with clotting. So inflammation of the veins, that can either be what? Superficial or deep vein thromboses. What are the signs and symptoms? If it's superficial, you might be able to, like I said, palpate that. A lot of times that you can actually like kind of palpate the cord. You can, if you look down, you can see that you have veins that are superficial, and if one of them had a phlebitis, you could touch it and it would just feel, instead of kind of rubbery and soft, it would be very hard. So deep would be, again, it's just these pain that you get in usually the legs. The risk factors are immobility, clotting disorder, recent surgery, previous DVT, and some sort of hypercoagulable state. An example of that off the top of my head would be sickle cell. There is some interesting cannabis relation to superficial venous thromboses, which was noted from e-medicine. So what is the workup? So if you see somebody having these types of symptoms, the main thing that you're going to get is an echo of you're going to send them to get an ultrasound, not an echo, get an ultrasound of the calf to rule out a deep vein thrombosis and to evaluate the vasculature there. But you may also want to be looking at other things, especially if you feel like it is a thrombophlebitis, because if it's a thrombosis, you need to make sure that they don't have some sort of hypercoagulable condition. So you're going to get a CBC, you're going to get a PT, a PTT, a protein C, an APC, a protein S, a antithrombin, an antiphospholipid, and so this is one of those things that you probably, it might be helpful to have off at the top of your head or just have that written down for a testing purpose. You would say, what are the most common labs that we run if you're worried about a hypercoagulable state? Can you list them off in your head? So just say that in your head right now, okay? Labs that you run to evaluate a hypercoagulable state: PT, PTT, protein C, APC, protein S, antithrombin, antiphospholipid. Those can be helpful in the evaluation of that. So hard cord-like vein, again, that would be indicative of an inflamed vein, but you need to make sure to see if it is thrombosed or not. And remember, if there is thrombosis in the vein, then it's basically you have a deep vein thrombosis or a superficial vein thrombosis, and you're going to be giving this person a anticoagulant, something like a factor 10x, Xarelto or Eliquis, or you're going to be doing warfarin or heparin. Varicose veins, kind of a step backwards as we review that. It's related to venous insufficiency. It is part of venous insufficiency. Varicose veins and telangiectasia spider veins are the visible signs of venous insufficiency. As a reminder, so this is your time to see how your memory is, what would be the signs and symptoms of venous insufficiency? There is no thrombosis, it's just the veins are not, where the vessels are not working very well. Leg heaviness, cramping, burning, pain, and tenderness of a vein, itching and night cramps, and edema. So those are some of the symptoms. Remember, the workup involves an ultrasound to rule out a deep vein thrombosis, but it can also assess the damage and the degree in which there is venous insufficiency. How are you going to treat this? You either are going to do compression socks just to manage it symptomatically, or they could consider some sort of surgery. There is some stuff when it comes to venous insufficiency that I had written down, and that was polydocanol IV, sclerotherapy, chemical ablation, laser therapy. So those are some of the things that vascular specialists will do. Moving onward, so instead of looking at, we're still on vessel diseases or vessel pathology. So instead of pathology of the veins, what would be pathology of the arteries? We've talked so much about coronary artery disease in the first part, so in this part we're going to focus a little bit on peripheral artery disease. Peripheral artery disease is also known as peripheral artery occlusive disease. The most common is going to be what? So you're thinking of coronary artery disease, it's its own little field. Outside of the heart, what is the most common artery that is affected by some sort of arterial occlusive pathology? The most common is the superficial femoral artery, which will feed into the calf muscle and can cause calf pain. So this would be a different thing that could cause calf pain aside from a DVT, aside from some sort of musculoskeletal injury. It could be a severe indication of the degree at which they are having some sort of artery disease. Now, what are the signs and symptoms if someone has a problem in artery disease or peripheral artery disease? Think of it just like a myocardial infarction. So if you are having, if you have some partial blockage of a coronary artery, if it was more complete, you're having a myocardial infarction. If it's partial, you're having angina. And angina is chest pain. And that chest pain acts how? Well, if you start to exercise, you're putting more strain on the heart, and it hurts even more, but it gets better with rest. So the same is true with the peripheral arteries. We call that claudication. Claudication is cramping pain during exercise, and it is usually reproducible with strain, but it will go away with rest. So that is absolutely important to know. More of this cramping, tightening pain that you're going to feel generally in the muscle as well. So if it was a superficial femoral artery, a partial occlusion, you may actually feel that referred pain in the calf muscle. So what is the workup? The workup of this is going to be doing an ankle brachial index. So diagnostics is the diagnostic gold standard is going to be an angiography, but an ankle brachial index can be helpful as well, not only to give the assessment, but to give you an idea of the severity of the occlusion. So peripheral arterial occlusive disease is less than 0.9 is what I had written down from eMedicine. But do remember, for diagnostic reasons, and angiography is the gold standard. How would you treat this? So I want you to remember, because it helps with coronary artery disease when you're thinking of peripheral artery disease, because they have the same underlying pathology with that occlusive state, you want to think the same exact stuff. So are their lipids managed well? Do we need to put this person on a statin to help with that? Does this person have hypertension? Do we need to manage their hypertension? Is this person diabetic? Do we need to get their diabetes under control? Are they a smoker? If they're smoking, we need them to stop smoking. You may also want to be giving them what type of medicine? Some sort of anticoagulation medicine, the most common one used in coronary artery disease, as well as in peripheral artery disease, is aspirin. And what could you do if this is very severe? The way to really treat this, if it's absolutely severe, is going to be some sort of surgery. The one thing I forgot also to mention as it comes to treatment, and that would be lifestyle changes. Do not forget, diet and exercise can make a significant difference in peripheral artery disease as well. So pain that occurs when walking, alleviated when sitting, ankle brachial index. Now sometimes if the occlusion was to get really serious, you could have what they call a limb attack. If there is complete occlusion in one of these peripheral arteries, then what happens? It completely blocks off. If that were to happen, you would see some cyanosis, or your limbs would go white, as well as if you're checking for pulses, peripheral pulses, if there is no pulse, then that could be an indication of this. Usually the limb would also get cold. There is something called if you're looking for a good buzzword, Berger sign. Berger sign is if you elevate a red foot, it becomes pale, and that is an indication of peripheral artery disease as well. So, moving forward, we have arterial embolism and arterial thrombosis. Arterial embolism or arterial thrombosis is a clot or thrombosis of an artery causing ischemia or death. This can occur in many places. So I probably should have began this before I went into peripheral artery disease, because it can occur in many places. So this is a step back just to review everything we've talked about when it pertains to coronary artery disease as well as peripheral artery disease. But think of it in this way: a clot or thrombosis of an artery. This causes ischemia to the places in which that artery was feeding, and that can even lead to death in the sense of a myocardial infarction. It can occur in many places. If it occurred in the brain, it would lead to what? It would lead to a stroke. If it occurred in the heart, it would lead to a myocardial infarction. If it was occurring in the extremity, it would lead to peripheral artery disease, could cause limb death. Distal superficial femoral artery is the most common one, and iliac artery occlusion is another form. So, signs and symptoms, it all depends on the location. Remember, claudication is going to be indicative of peripheral artery disease. Angina is indicative of cardiovascular, coronary artery disease. If someone was to have some sort of neurological symptom, it would be a cerebrovascular disease, something like stroke-like symptoms. So remember what the risk factors are that cause these, and it would be the same risk factors such as smoking, obesity, diabetes mellitus, a sedentary lifestyle. When someone has an embolus or some sort of arterial thromboembolus, then what you're going to have to do is they will need anticoagulants to prevent further spread. I saw someone even just a week ago, as an FYI, who said he had a clot in his vein. So he had a CVD, cerebrovascular disease, and he said that the clot is still there. It's a 7-inch clot that is still in one of the vessels of his brain, but he's taking the anticoagulants so that there are no more future clots. And they couldn't do surgery on it because it's in the brain and it's not a very easily accessible spot. So you have things such as anticoagulants that are used to manage that to prevent risk of further emboli. But if you are able to get it and it's in an area that you can access, then you can do some sort of a catheter and stent and surgical removal. Iliac artery occlusion, it's related to peripheral artery disease, obstructive plaques or atherosclerosis in the iliac artery. So another name would be AKA aortoiliac occlusive disease. Risk factors: hypercholesterolemia, smoking, diabetes mellitus. Signs and symptoms: number 1, claudication. What is claudication? Remember, it is basically angina, but in a limb. AIOD, aortic iliac occlusive disease, is mostly the calf, but it could be the butt or the thigh. Remember that the pain is crampy, it's pain, and it's usually felt more intense during exercise, and it is alleviated with rest. There is something that occurs. So if you had no femoral pulses and claudication in your butt and even erectile dysfunction, so no femoral pulses, butt claudication, and erectile dysfunction, what is the name of that syndrome? That is Leriche syndrome. Leriche syndrome is no femoral pulses, butt claudication, and erectile dysfunction. Remember, the workup of peripheral artery disease would be lipids, A1C. If you're going to catch some sort of peripheral artery, occlusive artery disease, how are you going to diagnose that? It's usually going to be with CT angiography. The DVT you can assess through a ultrasound. If you were getting some sort of a thoracic, remember, if I'm going back, if you had a abdominal aortic aneurysm, that you can assess with an ultrasound, but if it was a thoracic aortic aneurysm, you would need a CT. Other things that are helpful when you're looking at peripheral artery disease, including iliac artery occlusion, would be ankle brachial index and seeing if it is less than 0.9. Remember the treatments, managing the risk factors, and surgery. Temporal arteritis. So temporal arteritis, another one of its names is what? Temporal arteritis is also known as giant cell arteritis. What causes temporal arteritis? We don't know. It actually has an unknown etiology. It is considered a systemic inflammatory vasculitis. So some sort of inflammatory condition that is causing inflammation of the temporal arteries, those vessels. It is strongly related to a particular rheumatological condition. What is the name of the rheumatological condition associated with temporal arteritis or giant cell arteritis? That would be polymyalgia rheumatica. If a patient presented with scalp tenderness or jaw claudication, you should think of temporal arteritis. Those are two big buzzwords that are associated with this: jaw claudication and scalp tenderness. They may also have symptoms such as headache, neck pain, and visual loss. Risk factors: greater than 50 years old, someone who is smoking. The workup is usually done through some sort of an ESR, CRP, so you are looking at these inflammatory markers. The absolute diagnosis of this, though, is going to be made with a temporal artery biopsy. So on physical exam, it usually could be tender, like you can feel some of the temporal arteries, and they would be tender in that spot. But jaw claudication, so imagine if someone is chewing and eating, and they're feeling pain in their jaw when they're moving. Scalp tenderness was that big one. And again, it could even result in some sort of visual loss. That is temporal arteritis. How do you treat this? The treatment is steroids, 4 to 6 weeks. The treatment of temporal arteritis or giant cell arteritis is prednisone, 40 to 60 milligrams a day for 4 weeks, or until symptoms resolve or until the ESR normalizes. Moving onward, we have acute pericarditis. Acute pericarditis is an inflammation of the tissue, the outer wall of the heart. What is the big buzzword for acute pericarditis? The main sign and symptom, or the main thing that you need to have associated with this? The biggest thing associated with acute pericarditis is going to be diffuse ST elevations on the EKG. It is not just in contiguous leads, but it is in every each lead. V1, V2, V3, V4, V5, V6 all have ST elevations, and that is going to be an indication this person has acute pericarditis. The other thing that would be helpful for this is these patients, you're going to be running cardiac enzymes and not just basing your diagnosis off of the EKG, and all the cardiac enzymes are going to be absolutely fine and normal, and they're going to be still having chest pain. They have these diffuse ST elevations, so this is kind of a home run or grand slam, whatever term you want to use. What causes acute pericarditis, this inflammation of the pericardial wall? 25 to 84%, which is a stupid percentage range to give anybody, is idiopathic. We don't know if it's viral or it could be related to a rheumatological condition. It just kind of occurs without us knowing. What are the signs and symptoms? Well, if you had inflammation of the pericardial wall, you should have chest pain. And if you have chest pain, you are doing an EKG. And if you do the EKG, you will see the diffuse ST elevations. And you can also get the cardiac enzymes to make sure it's not something else. And at the end of the day, you make your diagnosis of acute pericarditis. The pain is usually worse with inspiration. The pain is relieved when sitting forward. So these are things that people love putting on tests. So a person with chest pain, they may come in kind of hunched forward because they know that it doesn't hurt as much there. They could have a fever or a murmur. The pain is worse lying down. If they lie down, it puts so much more pressure on the heart, and that's going to be something that's really going to make you strongly think of acute pericarditis. How do you treat this, though? This is the scariest thing. I think in real life, these patients are probably still hospitalized for monitoring, but the actual treatment is just not steroids, but anti-inflammatory. Non-steroidal anti-inflammatory medications, NSAIDs, are the number one treatment for acute pericarditis. Colchicine is used sometime. So that's something you'll probably find on a test because people love to say patient presents with pain that is relieved when they are hunched forward, but when they lie down, it's far worse. What is the diagnosis? What are you most suspicious of? Acute pericarditis. Patient presents, EKG shows diffuse ST elevations. What is the treatment? It's NSAIDs. So that's where you're often going to see things like that showing up. Other things related to the pericardium is going to be a pericardial effusion. Pericardial effusion, you need to, if I say pericardial effusion, you should have this pop in your head immediately. I say pericardial effusion, you say Beck's triad. Beck's triad is hypotension, jugular venous distension, JVD, and muffled heart sounds. That is the triad that is used to diagnose. And the reason why that is significant, if someone has JVD, hypotension, and muffled heart sounds, what are you going to need to do? The treatment is a pericardiotomy or pericardial centesis, thoracotomy, or sternotomy. That's what they have written there. Basically, the pericardial centesis, pericardomy, they're actually going to have to make an incision in the pericardium to relieve some of the pressure there because there is fluid that is built in there. And if you have fluid surrounding the pericardium, then what's going to happen? The heart's not able to pump the way that it normally would. So you're having some very severe congestive symptoms, which would be what JVD is, and the muffled heart sounds, because when you go to listen to the heart, there's all this extra fluid there that makes so the sound is much different. And just like with acute pericarditis, the pain is far worse when you lie down, and it's relieved when people are leaning forward. They have chest pain and pressure, lightheadedness, palpitations, cough, dyspnea, hiccup. Those are symptoms of it, but the most significant is obviously the chest pain, and it's far worse when they're lying down. But with acute pericarditis, they're not going to have congestive heart failure symptoms. They're not going to have muffled heart sounds. Those are going to be just fine. This patient, you probably are going to get an EKG, and guess what you're going to see on the EKG? Diffuse ST elevations. So that diffuse ST elevations is not actually specific to acute pericarditis. It is also symptomatic of pericardial effusion. The main thing is does this person have muffled heart sounds and JVD? Do they have congestive symptoms? Because if they're having congestive symptoms, you need to be thinking that this is a pericardial effusion. If it's not, if they don't have those congestive symptoms, then you can say this is just a pericarditis, and we can do the evaluation. There are some things that you'll see, though, because if you are suspicious of an effusion and you're trying to rule this out, so the person that you're suspicious of with pericarditis, you're trying to make that differentiation between an effusion and acute pericarditis, things that will help you with that are, again, the congestive symptoms, but you can also run an x-ray, and on an x-ray, you will see what they call a water bottle heart, because again, there's all this fluid surrounding it, and so it's going to change what the visual is on an x-ray. The absolute diagnosis would be an echocardiogram. Again, chest pain is not something we take lightly, so if someone has diffuse ST elevations, what are you probably going to be running before you even go to the x-ray? Because the x-ray is not as significant and not as sensitive and specific, you're going to be getting an echocardiogram. So with that patient that we are still running hypothetically that has chest pain, you did the EKG, they have ST elevations, you probably are going to go run an echo just to make sure to rule out an effusion, because if it's an effusion, they're going to need, instead of just NSAIDs, they're going to need a surgical procedure. So, cardiac tamponade. Cardiac tamponade is fluid in the pericardial space. So, what is pericardial tamponade and pericardial effusion? I have both of these up so you can make some sort of differentiation. So so you have these two things. This is how you differentiate pericardial effusion and a cardiac tamponade. Most of what I just read with a pericardial effusion is a description of cardiac tamponade, that Beck's triad. If you have the Beck's triad of JVD, muffled heart sound, and low blood pressure that's usually less than, if they have blood pressure lower than 90 systolic, then they have a cardiac tamponade. And so it's more like you have to think of this as a spectrum. You have acute pericarditis, which is its own separate thing, but an effusion can progress. It can be minimal. You could just have a minimal effusion there that isn't actually causing cardiac tamponade. It becomes a cardiac tamponade once you have Beck's triad. So Beck's triad equals cardiac tamponade. Now, if you have some fluid in the pericardial space that hasn't fully gotten to the point where you're having Beck's triad, then I guess they just call that a pericardial effusion at that point. And the risk of the pericardial effusion is that it progresses into a cardiac tamponade. And so if a person had fluid in the pericardial space and they have a pericardial tamponade, this is an emergency as it can result in cardiogenic shock and death. What do you do? It is an immediate subxiphoid drainage, a pericardiocentesis. How is a pericardiocentesis performed? A pericardiocentesis is performed by injecting a needle in the subxiphoid space, and that will be able to get into the heart. And then it's done using a needle and a small catheter, and you're just going to get it there. And once it breaks through the pericardium, then you're going to start to see a bunch of blood start to fill that, and you drain that. And so I apologize for conflating pericardial effusion and cardiac tamponade. The main thing from a clinical perspective is if a person has chest pain, what do? You do an EKG. If that person on the EKG shows diffuse ST elevations, you're going to get an echocardiogram. The echocardiogram will be diagnostic of a pericardial effusion. Now, if in the same instance, the person who has chest pain, they're hunching over and they say, my pain is tremendously worse when they lie down, you may have to lie them down and see if they have JVD. You'll check their blood pressure, and if this person has low blood pressure, less than 90, they have this JVD, and you listen to their heart and it's muffled, then what are you going to do? You're going to need, this person has a cardiac tamponade, and you're going to need to do an immediate subxiphoid drainage. Whereas if they have stable blood pressure and they may have muffled heart sounds, but they don't have the JVD, then perhaps at that moment in time, you're still going to be monitoring that. These patients obviously can destabilize quite quickly, so they're going to be rushed in the emergency room, and they're going to run their protocols there for what to do. But it's nice to know that after a pericardiocentesis, you're probably going to have them continue to be monitored in the hospital, and they may need further surgery where they might do a pericardiotomy. So, again, a lot of the things that are similar that we mentioned a pericardial effusion are also pertinent to a cardiac tamponade. That would be X-ray, water bottle heart, chest pain, chest pressure. There is something also indicative of a cardiac tamponade and pericardial effusion, and that would be pulsus paradoxus, which is a drop in blood pressure with inspiration, less than 10 millimeters of mercury. So, what are some of the risk factors for a pericardial effusion and cardiac tamponade? malignancy, uremia, infection, idiopathic, and trauma. Trauma is the other one that can cause that. So the last things that we have to cover are going to be some of these valve problems. The nice thing with the PANRE is that they do not have you memorize all of them, and they were a mess to begin with anyways. So the ones that we have are mitral regurgitation, aortic stenosis, and mitral valve prolapse. So aortic stenosis, I have as a stupid mnemonic for it, AS. So AS, aortic stenosis, is, this is how I remember it, it's not that helpful, but aortic stenosis has a crescendo, decrescendo, systolic murmur. So aortic stenosis is systolic. That spells ASS. For some reason, it's really easy to remember inappropriate things. So what happens to a person's butt? It gets bigger as you grow up, and then as you get older, it gets smaller and smaller and smaller. So crescendo, decrescendo, that's what butts do in the process of life. They slowly get bigger, and then as you really get aged, they get smaller and smaller and smaller. And so that's how I remember aortic stenosis, crescendo, decrescendo, and that is a systolic murmur. How are these diagnosed? Every single one of these is going to be diagnosed with a echocardiogram. Echocardiogram is going to let you look at the anatomy, and you can actually look at the problems in the valve. All of these are the way that they try to torture you in school and with testing is to be able to identify these based off of heart auscultation. And so, in real life, basically, in real life, if you have any type of murmur, just get an echo and then you'll get your diagnosis. It's as simple as that. In a testing setting, they want you to know these classical phrases. So crescendo, decrescendo, systolic murmur, think aortic stenosis. So aortic stenosis is the aortic valve between the left ventricle and the aorta. Aortic stenosis means the valve becomes stiff and obstructs. What would be the cause of an aortic stenosis? Why would this valve all of a sudden become stiff and then start to cause some obstruction? It's most often a congenital deformity, but it can also be a secondary thing to rheumatic heart disease, and rheumatic heart disease is secondary to strep infections. So it's nice to know some of that pathophysiology. The symptoms are usually, if you're having some sort of a stiff valve, then you're going to start to have congestive heart failure symptoms. So they may present with some chest pain. They may present with the symptoms of congestive heart failure, which would be that swelling in the legs, edema, dyspnea on exertion, orthopnea, shortness of breath, dizziness. And so the echocardiogram is how you make the diagnosis. The treatment, if it was minor, then they may just watchful waiting until it becomes symptomatic. What they said on eMedicine is on average death occurs 5 years after angina and 1 year after heart failure. So it's obviously not something that's that emergent to act on, but as soon as someone has symptoms from aortic stenosis, they're probably going to need surgery pretty quickly, because within the year they'll probably die if they start to get chest pain as a result of this. And the idea is this person has chronic chest pain, so they ended up getting all sorts of tests, Holter monitor, EKG, and eventually you just did an echocardiogram, and then they find this. So the ultimate treatment for this is going to be some sort of surgical treatment, and that is an aortic valve replacement. So crescendo, decrescendo, systolic murmur is aortic stenosis. Mitral regurgitation is abnormal blood flow from the left ventricle to the left aorta because it is regurgitating. Normally blood goes from the left atrium, not aorta, I said that earlier, to the left ventricle, but because there is some valvular damage, it's flowing backwards. So how would you end up catching that? It would have to be through an echocardiogram. As we mentioned, all of these valvular disorders of the heart are going to be diagnosed through an echo. So mitral regurgitation is a holosystolic murmur. Holosystolic murmur. What are the signs and symptoms? The same thing, congestive heart failure symptoms, fatigue, dyspnea on exertion, reduced cardiac output, pulmonary edema, palpitations, or chest pain. This is, again, a very stupid way of remembering mitral regurgitations, what you're going to notice on auscultation. So mitral regurgitation is MR. MR is the consonants found in the name Mary. And Mary, mother of Jesus, was a holy woman. So holy systolic murmur is mitral regurgitation Mary. Mother Mary, holy, saint-like, holosystolic, MR, Mary. That somehow helps me, just like you have ASS is crescendo decrescendo, aortic stenosis. You can now remember holosystolic, holy systolic is Mary, mitral regurgitation. Mitral valve prolapse, MVP. MVP is a mid to late systolic click, or a systolic murmur that is at the cardiac apex. So this is another stupid way of trying to understand this, but you think of an MVP. MVPs either occur at their apex when they're at their best. So you're the MVP when you're at the best of your career, or maybe you are the MVP a little bit late, so it's a late systolic click. MVP, late systolic click, or systolic murmur heard at the cardiac apex. Systolic murmur, apex, MVP, mid to late career. Systolic click is going to make you think of MVP, which is mitral valve prolapse. What is known about mitral valve prolapse? MVP, mitral valve prolapse, is the most common valvular abnormality. 2 to 3% of the population has it. It's usually benign and asymptomatic. It can put you at higher risk for what conditions? A mitral valve prolapse puts you at higher risk for endocarditis, stroke, or even mitral regurgitation. MR, mitral regurgitation, Holy Mary, is holosystolic. Remember that. And it has the same symptoms, signs and symptoms of everything else we've been talking, which are kind of congestive heart symptoms, congestive heart failure symptoms, fatigue, dyspnea on exertion, CHF, palpitation, postural nocturnal dyspnea. Risks. The risks would be, if you were to think about if there was going to be some sort of valvular abnormality, one of the things that puts you at risk for that is obviously genetics. And some of the specific genetic stuff to recall would be things like Marfan syndrome or Ehlers-Danlos syndrome. And those you can detect by hypermobile joints, scoliosis, kyphosis. Those are things that I think another thing that you'll see is pectoris excavatum, are things that you'll also find in syndromes like Marfan's or Ehlers-Danlos, because they have these connective tissue disorders. And if there's problems with connective tissue, it can also affect the connective tissue, affecting your heart and these heart valves. So, diagnosis is made, as all of them are made, with an echo. And the treatment is watch and wait, echo every 3 years. And if it's severe and they're getting symptoms, then you want to do surgery. And that will be done through a cardiologist referral. Mitral valve prolapse, MVP, either at the apex of your career or mid to late systolic, so mid to late or at the apex of the heart. And AS, atrial stenosis, systolic murmur that crescendo decrescendo, but gets bigger as you grow up, and then as you get a little bit, it starts to descend a little bit. And then the last one, MR, mitral regurgitation, MR, Mary, holy systolic. There you go. That's cardiology for the PANRE.